Hi, everyone. Good morning, good afternoon, good evening from everywhere you are joining us across the globe. We are so happy to see you all today, especially those ones joining us for the first time in this webinar. On behalf of the Operating Room Global Education, Innovation and Research, and our CEO, Professor Adebosola, I welcome you all to this interesting global webinar. The theme of today's section is building the global preoperative workforce among nurses. When I talk about nurses, I'm talking about both the scrub nurse, the recovery room nurse, and also the secretary nurse, then the anesthetics, the surgeons, and every other healthcare professionals in the operating room. And this topic is so interesting because once there is shortage, it impacts surgical care worldwide. It directly impacts and affects patient safety, access, and even outcome. So I want you to, sit tight, prepare your questions because there will be time for a question. And I will also need you to ask your question. Also, my name is Blessing Ugwu. I'm member of TORG Education and Training Team. I'll be serving as the coach here today. And I also have my colleague here, Mr. Sunday, who will also introduce our distinguished speaker, Dr. Washington. Thank you so much, everyone, for joining us. You're all welcome. Please, Mr. Sunday, the mic is yours. Thank you.
Okay, from Nigeria, I say once again, good evening to all of us participating in this educational program. Just like my colleague Ugwu has said, it's a beautiful program, and I hope at the end of the day, we will take the benefits and see how we can impact positively on perioperative nursing. Today, we have, we want to say, genius as far as the healthcare industry is concerned. She's put her foot in the sand of time. I'm talking about Dr. Nikki Washington, DNP, MBA-HCM, RN, CNOR, CSSM. Currently serves as Director of Surgical Services at St. Joseph's Hospital Medical Center in Stockton, California, where she is responsible for ensuring the financial sustainability, long-term viability of perioperative commitments of perioperative services. A transformational leader she is. Dr. Washington is widely recognized for her commitment to advancing leadership development and equipping perioperative personnel with the tools necessary for success in today's complex surgical environment. Her influence extends beyond the hospital walls, as she is actively engaged in community leadership by delivering educational presentations to underserved populations and mentoring emerging health professionals. Her contributions to nursing leadership have earned her multiple organizational accolades, including recognition by Marquis, who top healthcare professionals for her dedication, achievement, and innovation impact in perioperative nursing. Dr. Washington has played a critical role in handwriting evidence-based policies and procedures throughout perioperative and procedural services, employing an interdisciplinary approach to reduce patients' safety risk and strengthen quality outcomes. As a dedicated member of the Association of Perioperative Registered Nurse, AORN, Board of Directors, she brings strategic vision, financial stewardship, and a proven record of effective outcomes to national conservation on surgical services excellence. At the core of her professional journey, Dr. Washington's ultimate inspiration remains her family, her children, aged 35, 30, and 13, and her cherished grandchildren, aged 11, 9, and 5. She attributes her strength and resilience to the favor of the Most High, emphasizing that her family continues to be her guiding purpose and enduring reason why. Ladies and gentlemen, it's my pleasure to hand over the floor, the mic, and everything she needs to do a beautiful job this evening to Dr. Nikki Washington. My pleasure, Doctor. You're welcome.
Hello, good morning, evening, and afternoon, everyone. Thank you so much for that wonderful welcome. It is truly an honor to be here. I believe this gathering, this meeting is more than just about nursing. It's a global movement for healthcare and for patient equity, for the care of all individuals globally. Although we are in different regions and different time zones and different climates, we all face a certain and the same barriers as far as surgical services is concerned, as well as nursing is concerned. So allow me to share my screen. All right, give me just a second. I'm working with technology here. Here we go. All right, can everyone see my screen? Thumbs up if you can, thumbs down if you cannot. All righty. Okay, as stated earlier, my presentation will be over building a global perioperative workforce, nurses, surgical technologists, anesthesia providers, and surgeons in short supply. So the overview would be over global surgical demand increases, workforce shortages as a barrier, international relationships, and education repositories. So as we all know, we are entering this phase of gloom. By 2030, about 73% of the nursing workforce will be retiring, and we are referring to the baby boomers. Baby boomers make up about 80% of hospital admissions, and that's for nursing and non-nursing. Now, the hospital or nursing shortage this is not anything new. I can remember as a little girl, because my mom is a nurse, at 8 years old, she told me in the 80s, and I'm dating myself, about a nursing shortage. Now, we have to think about what has been done in between that time to mitigate that. Well, the WHO recommends that or suggests that by 2030, 13 million nurses will be needed. A lot of that is due to distribution of workforce from a nursing perspective and from a physician perspective, as well as the AAMC forecast increased estimates for surgical services to be increased from 71% to 79% from the years of 2019 to 2034. Now, what does that mean? What that means is there is an impending, and it's transglobal. It transcends across disciplines. It's not just isolated to nurses. It's not just isolated to anesthesia providers, and it's not just isolated to surgical techs or surgeons. We are in an aging time where, as I stated, the baby boomers are going to be retiring. They make up the majority of our workforce. And so what pipelines and what has been done for us to curtail that? Did we wait too long to try to mitigate the barriers? I think a lot of times we take things for granted and think we have time, and time is truly of the essence. And if we're honest with ourselves, if we're still stressing about it now in 2025, almost 2026, we're still behind the curve. So the increased demands for the U.S. residents 65 and older, are predicted to increase by 55% by 2030. Residents 75 and older are predicted to increase by 73% by 2030. Now, what that means is that they require more procedures because of their health requirements and aging disease processes. They require more procedures for general anesthesia or moderate sedation. If you keep up with global times and changes and innovations where healthcare has gone, especially in the operating room, a lot of things that were done in the operating room are no longer being done in the operating room. With the expansion of ASCs, we have seen an estimated growth of 43% of ASCs. Now, the big total joint procedures, those are transitioning from your hospitals to ASCs. So when you have all of these transitions of services, now you have an increase of demand for anesthesia providers. Technology and innovation in procedural areas also play a vital role. You think about areas like the cath lab or IR, where procedures such as bypasses, not the major open heart bypasses, but the bypasses that can be done in an interventional setting, such as the cath lab, or the endoscopy procedures or neuro procedures in IR. A lot of those carotids and things like that were done in the operating room. They are still performed in the operating room. However, a lot of those have transitioned to procedural areas. That it is an increased demand for anesthesia providers, that it is an increase for staff, knowledgeable staff, not just staff just to have a body in the room to cover cases, but staff that have competencies for those areas. So with an already impending, with barriers that are already there, then you add the ASC expansions with the expansions of the non-operating room anesthesia coverage areas, like the cath lab, the GI, and IR. You're just compiling. We haven't fixed anything. We have to a little point, but the overall overarching picture is that we're still behind, because those areas are blooming, right? They're bursting out of the seams. And so we don't have enough anesthesia providers to catch up with that. So you have to ask yourself, in your region, in your area, what does your model look like? What does your operating room team look like? Is it made up of anesthesia providers such as CRNAs, anesthesiologists, anesthesia assistants? What does that look like? What does your nursing component look like? Do you have surgical techs, or do you have nurses only that scrub and circulate? For your surgeons, do you have a residency program where you have fellows and residents to create a pipeline, a continuous pipeline, to make sure that you have sustainability? So the U.S. Department of Health and Human Services predicts an estimated deficit of 24,340 overall physicians by 2034. Now, globally, low, middle to income countries have a decrease in anesthesia providers and surgeon coverage. Now, this could be, according to literature, this can be for a couple of reasons. It could be that the individuals are transitioning from the lower to middle income countries to higher income countries due to infrastructure, due to pay. Unfortunately, we try to get away from that overall question of money and pay as it refers to equity, but the reality is it's a real thing, and it happens. The Lancet Commission on Global Population estimates that 30% of patients have disease process requiring surgery. So what does that look like with a booming volume? And what does that look like when you don't have enough providers? You don't have enough anesthesia providers to cover the room. You don't have enough surgeons to do the procedures. You don't have enough staffing to cover those rooms. It seems like we're always in a crisis. We're always in a staffing crisis, and we're always trying to use a backup emergency plan to cover the backup emergency plan, which is not sustainable. It works in the moment, but it's not sustainable. And ultimately, it leads to a lot of different factors. It leads to hospital financial and operation constraints, which is a long time phenomenon that no facility can withstand. It can help just a little bit, but it's not sustainable. So the impacts of care, you have delays in care. You have patients that are waiting to have procedures done because, number one, there's not enough personnel to open up the operating rooms. Now, you may have these large facilities, or you may have these organizations that have the rooms, but they don't have, and they have the volume, but they don't have the capacity of the staffing. They don't have enough anesthesia providers. They don't have enough staffing personnel, and it depletes the entire OR team. Because one thing is for sure, you cannot have a complete OR team or run a complete room if all of the components of your team are not available. Now, I know, and I'm not going to speak for here because I can't, because it won't be true. However, there are some organizations that, for operational purposes, they cut corners to manage staffing. And when you cut corners to manage staffing, you are truly going against your oath in your code to keep patients safe. You really shouldn't compromise patient safety just to say you're getting cases done. That also leads to higher morbidity and mortality, especially in your lower income communities. Those patients tend to be, and I can speak for our area, we have a population of high acuity patients, and they don't always come to the hospital in a timely manner. And so by the time they do, it's critical, okay? They have higher morbidities. And when they wait, they're already waiting. And when we have delays, that just continues to perpetuate their inability to gain the care that they need. Health equity amongst all individuals is a must. And that is something that we need to be intentional from a global standpoint to make sure that all patients, all ages, obtain optimal patient care. Impacts of care, it also leads to burnout and attrition rates. So when you're burnt out, we use this concept of lean. So lean has taken on a whole new meaning. Lean is supposed to refer to lean and standardized processes to promote efficiency. Right now, what is being felt globally is lean is meaning lean staffing, working with doing more with less. Okay, lean has taken on a whole new different meaning. And what that leads to is burnout. Now, burnout only lasts for so long. Sometimes you can push through burnout, but what does that do? Does that lessen your ability and make you less empathetic? Does it make you less engaged? The answer could be yes or no, but either way, burnout can lead to patient harm. It can lead to increased errors, medical errors. The literature states that increased burnout increases the risk of medical errors, such as medication errors, such as wrong diagnoses, and just inappropriate care being provided or things that are being missed because someone is burnt out. The mind can only take so much. So with burnout, what do you have? You have a higher attrition rate. You have people that leave. I think about the nursing component and the newer nurses that come in and they only stay in the workforce for 2 or 3 years. Now that's due to a lot of different things. It could be contributing to nurse bullying. Sometimes nursing is just not for everyone. And I don't think everyone gets involved in nursing for the right reasons sometimes. However, from a burnout perspective and nursing incivility or lateral violence, a lot of times in the research suggests that those nurses are burnt out. And what they do is that energy and that burnout translates over to the newer nurses that they are supposed to be nurturing and helping to cultivate what they have. But they eat their young. That's an old term that has been around for years, and unfortunately, it's still being done. But that burnout translates over to that. And so that's why you have the newer nurses, they will not stay in the workforce longer than 2 or 3 years. As a matter of fact, 23% of them exit nursing altogether. So again, all of this, in essence, compromises safety, it compromises quality, and it compromises efficiency. From a global policy and advocacy perspective, we must align with the United Nations Sustainable Development Goal number 3, which is to provide safe healthcare for all individuals of all ages. Invest in workforce development, and I'll elaborate about that. And also international collaboration with a robust strategic plan, sort of kind of like what we're doing today, right? It's a lot of different countries here. We're in a lot of different time zones. However, we struggle with the same barriers, whether it be the aging workforce, whether it be resource, inability to have the resources that we need, but we share a common barrier. And so effective collaboration globally builds a sustainable workforce. So I think about from a nursing perspective, and I'll go back. Let me go back one. So with investment in the workforce development, you have to make a conscientious decision to be involved and to be invested. You have to selflessly provide your time and be intentional in your efforts to have those collaborations, forge those partnerships within your community, within your organization, and outside of your organization and community. These are times when we cannot work in silos or let pride or ego get in the way from reaching out to our counterparts down the street, another community hospital or another hospital within the vicinity. Because what happens is everyone's working in silos on the same thing. And even though they're working in silos on the same thing, a lot of things are being missed because you don't have a meeting of the minds, putting out all of the information where everyone can work together. So from a nursing perspective, there are resources at our fingertips, literally. We think about the age of technology where everything is at your fingertips. I can remember going to the library, looking up books for resources and looking up things that way. Now we have it easy. We just put it in our hands, go to Google, and Google will tell us everything we need to know, right? So the International Federation of Perioperative Nurses is one major collective repository that all of us can utilize. We also have to forge and create our own residency programs. Not all hospitals have nurse residency programs, and I will challenge you all. If you don't, I would say why? Why not? There are a lot of brilliant minds on this call. All it takes is someone to step up and start moving and working forward and gathering the right stakeholders to create a sustainable and meaningful, fruitful RN residency program. Even if it starts with 1 or 2 students, we can start from somewhere. Partnering with nursing schools, and when I say nursing schools, I mean universities and community colleges. I think nursing as a whole, especially in the United States, I think we have done ourselves a disservice in some states of the United States by only targeting the universities or the bachelor prepared nurse to bring them into the workforce. Associate degree nurses or diploma nurses are still registered nurses. And so if we want to set the standard for only bachelor prepared nurses, we need to foster and cultivate those other nurses and include them in the growing progress. And I mean the same thing for your licensed practitioner nurses or licensed vocational nurses. but partner with the nursing schools, see what type of offerings they have. Do they know anything about the operating room? We have to create these partnerships to have a pipeline, because that's the only way that we can take a stand. And in our community is by creating those pipelines. So partnering with those nursing schools, reaching out to those deans of nursing, asking them, do they know about operating room nurses or nursing, or what do they know? Make an appointment to go and speak with one of their classes, create some time, and just talk about the role of the perioperative nurse. What does that mean? I honestly believe we are a true hidden gem that works behind the scene that a lot of people don't know about. Work with them, allow them to come into your space, create those partnerships with them, and involve all key stakeholders, meaning your administrative department, your C-suite, so that those conversations can take place. You'll have a pipeline. If those nurses can come through your operating room as a rotation, not just a 1 or a 2 day, but an actual rotation through the operating room. On a larger scale, there are resources available to work with the nursing schools to create an OR elective. And what that does is an elective class, and it prepares the nursing student early on in their nursing career, because you don't want to get them at the end when their mind is already made up to go to the ER or to the ICU. You want to obtain them and capture, what am I trying to say? Captivate them with the OR early on. So create those curriculums, work with your educators and your experts to create curriculums for an OR elective. There are resources out there, so you do not have to reinvent the wheel. That is available. AORN has a lot of that already, because they've done that with one of the major universities in the United States. When I was in Houston, worked with colleagues of mine, and we created that partnership and that elective for 2 of our universities, nursing schools, nursing universities in Houston. And so the resources are there. It's talking about it on calls like this, where we find out the information and we can share the information so that we can make a global impact for everyone. So that OR elective will allow the nursing students to understand the OR environment. Then they can go into the rotation during their rotation and their clinicals. And then the hospitals can have an OR residency program, and it's just a clear pipeline. And so it has to be intentional, and it has to start somewhere. And so I would implore all of you that it will start with you if you don't have it. AORN has a plethora of information and toolkits. It is truly a global repository of education. They have the ARN guidelines, they have Periop 101, they have Periop 202, which is geared more towards your cardiac, your orthopedics, or your GI for the procedure areas and the ASCs. They also have a lot of toolkits to help you start up programs. They have policy templates for you to help build policies. And they have the guidelines are forged in evidence-based literature and research. And that research literature are all part of the guidelines. There's also a platform called Concur Experience, and what that is surgical virtual reality simulation. You can use that for your surgical techs or your surgical nurses if they scrub and circulate. The individual actually puts on the VR headset, and they're working in tandem like they're working next to a surgeon. And they're learning how to work in the surgical environment. They're learning the instruments. They're learning how to pass the instruments. They're learning the art of anticipation at the surgical table. And so those are just small platforms, and I would love to try that. Small platforms to help grow your global perioperative platform, to help you grow and bridge some of these gaps. Those are some of the things that can mitigate the barriers. Again, I talk about the interdisciplinary partnerships. All of this sounds amazing and all of this sounds great. However, if your administrative department is not on board with this, it is not going to work. So when you create a task force or a group, make sure all key stakeholders are at the table. Make sure your C-suite is at the table, meaning your CNO. Your CNO has to be involved because she's nursing. He or she is nursing. Your anesthesia chief needs to be at the table. Your medical director needs to be at the table. Your chief of surgery needs to be at the table. The OR leadership needs to be at the table. It will not work if everyone's voice is not heard. I would also implore you to listen to your staff. What is your staff saying? Because they're the ones in the rooms. They're the ones that are able to articulate what those feelings are. They're the ones that see the lack in the rooms and feel the hustle and the bustle of, hey, let's get these metrics, let's do these turnover times. They truly know what it feels like and they know what's needed also. So don't count out anyone. Don't think there's a voice that should not be heard. Everyone's voice is important and powerful and should be heard. So you want to make sure in the beginning and early on to forge those interdisciplinary partnerships with the major key stakeholders, because all of what you may have may only just be as brilliant as it is. And all of this information that I just provided sounds real good, very engaging. It makes you happy. But if you don't have buy-in, it's not going to work. Work with anesthesia to see what kind of programs. Some facilities can have their own homegrown CRNA programs. Now, some facilities utilize anesthesia assistants. Those individuals do not have any prior medical background, from my understanding, but they are strictly trained and guided in anesthesia services of the surgical patient. And so a lot of facilities are moving to that model versus an anesthesiologist and CRNA model. And so we have to be creative but safe to restructure our current models. Surgical residency programs. Now, I talked about the OR nurse residency program, but what about your surgical residency programs where physicians are creating a pipeline to obtain surgical residents? If you don't have that, work with your chief. Work and see what type of things can be done for them to reach out to medical schools to bridge that gap. It's all about partnerships. I say this all the time. It's all about meaningful partnerships to create sustainability. Meaningful, effective, and intentional partnerships. So I will just say this, and it says conclusion, but it's not ending because it will never end because it's continuous. Workforce gaps threaten global equity. Unfortunately, that translates to we have to invest. It's not unfortunately, but we have to invest in our teams to have safe surgery. And the unfortunate piece is if we don't, we have a failing community of patients that lack care, that lack resources, and we have increased mortality and morbidity on an issue that we, in our excellence, have the capacity to change. All of us, again, on this call, has a voice, number one. Whether you do or you don't, you know someone that does. Surround yourself with those key stakeholders and the ones that you know will make a positive and forceful impact on your team to bridge these gaps. Utilize your resources. I just provided some resources for you all, and I'm going to send this PowerPoint so that you can have it and refer back to it. But take advantage of those resources. Remember our oath to keep our patients safe at all times. Do what you can do and don't think that you're not doing. Let me just say this. Don't not do anything because you think you're not doing enough. You don't know what you can do until you take the first step to work and walk in that vein and in that space. So this is something that I'm very, very passionate about. I love teaching. I've been in the OR almost 30 years in very different roles. I love speaking to audiences on patient care and the global impact, because it does not just affect me here, excuse me, or us here in the United States, it's global. We have to globally remain aligned with the Sustainable Developmental Goals. We have to remain aligned with the Lancet Commission. The Lancet Commission is a great integral part in any of the recommendations that WHO puts out. They are a task force that puts out the recommendations for health equity and for healthcare. And so we have to make sure we remain aligned, regardless of what it looks like and what those barriers are. We cannot sit back and not address those barriers. Talking about it all day is one thing, but you have to make actionable. You have to be actionable about it, not just talking about it, but being actionable. Have an action outcome. Have a plan, number one. Have a plan. Create goals, create teams, create committees, be intentional, create robust strategic plans, set up your SWOT analysis for your areas, surveillance your area. What works for you? What does the hospital down the street have that you don't have? Or what do you have that they don't, that you can partner together to forge gaps? Well, I'm sorry, not forge gaps, but to forge partnerships and close gaps and barriers. So I will end with that. And I just want to thank you for your time. I want to thank you for being able to be in this space with you all. You took the time out today to jump on this webinar, on this presentation, and I thank you for that. I think together we can make a lot of impactful change, whether it's through this platform or any other platforms, but from a global perspective. I'm not anything in the United States without my global partners. Our patients are not receiving optimal care in the United States without a global concept. And so again, I just want to thank you for your time. And I just want to say again, just thank you. Thank you. Any questions or any discussion for me?
Thank you so much, Dr. Washington. This presentation is so impactful and thought-provoking, especially when we see the impact of workforce shortage in the operating room. Okay, thank you so much for even creating your time to be with us here today. So this is time for question and answer. Please, if anyone have any question, please can you please type in through the chat box, or you can even raise up your hand and I will call you up for your question. I go through the chat box if there is any. Okay, I'm still waiting for your question. Okay, Dr. Washington, the question I want to ask is there any way maybe technology can help, improve this workforce shortage, maybe across the globe and even in low resource countries?
Can you repeat? I'm sorry.
My question is there any way technology, can help, help to address this workforce shortage, even in especially low resource countries?
Yes. So from my perspective, I think technology can work, as I was stating earlier, VR or virtual reality, that type of technology, or it can help out in various aspects. Yes, it can. When I spoke earlier on the virtual reality piece to building the team, not everyone has the resource or the infrastructure for a in-house surgical program. Right? If someone doesn't have a school for surgical technology to teach individuals how to scrub, you can always move to technology to bridge that gap, because there's a lot of technology out there to help in those capacities. From a staffing standpoint, with building a pipeline for building a program for surgical techs or your nurse that scrubs. As far as technology, we're in the age of technology, right? There's a lot of AI programs out there to help mitigate I'll say it on a simple level, like with your staffing, with your staffing as it pertains to productivity. A lot of times our staffing is up because we don't utilize our OR space appropriately. And so that means starting on time, turning over rooms on time, and you may not have a platform to help measure those key performance indicators. There is technology out there to help guide that, to decrease the burnout of the nurses, to decrease cancellation. And so there is a lot of AI and technology out there to address barriers in different stages and different aspects. So it depends on what barrier we want to look at. There is technology out there, I'm sure, to address all of those barriers.
Okay, thank you so much for that answer. That's interesting too. Okay, I'm still waiting for a question. Is there anybody that have any question? You can raise up your hand or you can type through the chat box. Okay, I also have another question. What advice can you give, young healthcare professionals entering into, operating room, especially in a busy hospital, where there is, shortage, despite the shortage. Some young people just want to, give up because of the shortage. So what advice can you give some of us? Because this will really help us too.
I would tell the younger nurses to just come in, be open-minded, be patient with themselves. So you have people, even younger nurses, nursing is a second career to them, right? And so when they've a different workforce or work source and then transition over into nursing, it's different. It's extremely different than being a nurse, than being a teacher. It's extremely different than being in other professions. And they just have to give themselves grace and be patient with themselves, because nursing is different. OR nursing is totally different. Nursing is different within its aspect, but OR nursing is totally different. The nurses that transition over, and I speak to here, from the nursing to the OR, and some of them did not stay because it was different. They were already introduced to another working type of environment. The OR is very hectic. It transitions daily, hourly, right? And so people have to give themselves grace. The newer nurses have to be patient with themselves and know and understand that, hey, it's not like any other field, but there's a main component to that. It's not just about them, it's about us, right? Who is the preceptor? Who is the mentor? Are we providing them the tools that they need to be successful? Because a lot of times, as I stated, the burnout that the nurses at the bedside and the OR have right now, that translates over to incivility to the incoming nurses. Okay. Operations in the operating room, like we were just talking about with technology. If those cases don't start on time, guess what? They're going to last longer. We're in an era now to where people aren't staying like they were 20 and 30 years ago to get these cases done. This newer generation, and I respect them, they honor work-life balance. Okay. And so if we don't have our operations together, those newer nurses are not going to stay. So it's twofold. The newer nurses coming in, be patient, give yourself grace, ask questions. There's no such thing as a dumb question, only a question not asked, right? So just ask the question, be open to learning. If you ever reach a point to where you can't learn anymore, then you really don't need to be in healthcare, because it's always changing. So we're always learning. And so just being open. Constructive criticism does not have to be taken negatively. Okay. Everybody is not going to receive a participation trophy. Everybody is not going to always, oh, you did a great job. No, that's not real. It's not realistic. Be open to feedback. Be open to the constructive criticism and use it as a tool to enhance, and to grow, versus taking it negatively. That's what I would tell them. But for us, again, I would say we have to be the change we want to see. We have to lead by example. We have to be nurturing and not being the opposite to these newer nurses coming in. So that's what I would say to both parts.
Okay, thank you so much. Thank you so much. That's interesting. So we have to be patient and ask questions. Thank you. Is taking, and I also know that every other young nurses here have also taken that. I also have a question from the chat box. The question here says, okay, however, we look at this matter, the third world country will be most hit as healthcare professional migration is more towards the Europe, America, etc. So the question is, what do you think these superpower nations can do to support the negative effects of these professionals' migration on their individual countries? I'm reading that from the chat box.
So what I would say is we have everything, to me, in my aspect, everything has a root, meaning everything has a why. You know, why did it start here? Or what is the issue? What is the barrier? And so when you can figure out what those instances are, I think you can tackle it. I can speak to what goes on here, right? I listen to my colleagues internationally of the barriers that they have. We have to, what we've done so far, we've made some strides, but a lot of it's not enough. It's not enough people speaking up. It's not enough people advocating for change. It's a lot of people sitting back looking at what's happening and what's going on, but there's not enough people asking those questions of why is this happening or what can we do to mitigate that. It's not anything that's going to happen overnight because we didn't get here overnight. Again, in the 80s, there was a nursing shortage. In 2025, we're still talking about a nursing shortage. So we have not done all that we can to get past these barriers. You have to pick a point of what those issues are, and you have to address it that way. You have to reach out and network and partner with these individuals in different countries or within your same region or country to see how you can work together to combat those changes that continue to perpetuate themselves. But sitting back, watching it happen is not going to do anything but keep us where we are. And just knowing it's not going to change overnight, it's going to take time, even if it's just incremental steps of improvement or no. And if I didn't, I hope I just gave 4 pearls of wisdom.
Yes, you answered. Thank you. That's exactly. Just gradually there will be a change. So another question from the chat box. The question is, how do you navigate with the shortage of workforce in your operating room in case of emergencies?
Well, I'm a working leader. So even though I am a director, I was a surgical tech before I became a nurse. So I've been doing this for almost 30 years. And at any given point, because we're always short, but at any given point an emergency comes up, my manager, myself, my manager, my nurse shift manager, and my educator, we are a team. So if an emergency comes up and it's not sustainable, I'm not going to say we do this all the time, but if emergency comes up, we are in the rooms. We have a team. If an emergency comes up, we just may sometimes have to pause the schedule and have a physician have a conversation with the other physician. Hey, we may need to bump your case because we have an emergency that has come up and mitigate it that way. But what we do is we address the emergencies. And
thank you.
Yeah, and work in the rooms. I came in about a month ago and scrubbed a case because my team was not, we have a new service line. And so we didn't have the volume for them to really get appropriate training. I know how to do it because I've worked in that space, but they have not. And it was an emergency, a true emergency, because doctors can call anything an emergency, and it's not a real emergency. But this was a true emergency where the patient's limb was at stake. And so it was a vascular, endovascular procedure. And it's time consumed. It's time predicated on time, right? And so they didn't know. So I came in and I scrubbed the procedure, but I had the tech come in and scrub in with me because I am a proponent of, you may not know how to do it, but I'm a scrub in and you're going to scrub in with me so I'm going to teach you while we're doing it so you can learn further and know for the next time. But I say we're not the traditional OR leadership team because we boots on the ground and we work. And we have a great anesthesia relationship with our anesthesia providers, where if there is no anesthesia providers available, the chief and the associate, they will come in and we'll start a room to get that emergency going.
Thank you so much for that answer, because that's very interesting, because we don't need to, leave the patient to suffer with the condition. There's need for everyone, no matter the position, to come in. Thank you so much. Please, is there any other question? Okay, the question I see here, the last question, okay, I have here, how do you manage conflicts and negative feedback in operating theater with your team? Because conflict is usually seen. So how best can we manage this?
Ooh, okay, so let me see how I can address this. So we are, again, in a different space with our generations, right? What worked for me, what bothered me, being in the operating room for almost 30 years, does not work for the newer generation. What worked for the boomers as far as behaviors of surgeon behaviors and staff behaviors in the operating room. What I do as a leader is set the bar and set the standard for professionalism, respect, and accountability. I have a model in the OR on the board, well, it's in the hallway on the board. It's called the 𝐂𝐸𝐧 principle, and it's about accountability. And it talks about behaviors. It talks about below the line behaviors and above the line behaviors. And we talk about communication, respectful communication. And so with below the line behaviors, and some of us, sometimes we're below the line at times, we're never always above the line, but we have to be accountable team members and take, and hold our counterparts accountable and keep them above the line. And so things that are below the line are gossiping, withholding information because you may have a individual that have been here longer, right? And they're withholding information for newer staff. They won't give them the knowledge and the information to work with a particular doctor. That's sabotaging. And so that is a work environment that we don't tolerate. It creates a toxic work environment. So we set the standard here as an organization that there will not be any toleration of a toxic work environment. And as the leader and as the director of the department, I am continuously redirecting staff. Hey, we have to work together. There would be no disrespect tolerated, and we're going to keep everybody above the line. I don't allow them to turn a blind eye. You can't turn a blind eye, because if you see it, then you own it, then you do it. And so just speaking and creating a safe platform for staff to feel like they can speak up. If you want staff to speak up about things and be positive, you have to create an atmosphere and an environment for them to feel safe and comfortable speaking up and bringing things to you, so they don't feel like leadership is going to even retaliate against them. So just creating a safe space and putting boundaries and parameters in place and making sure everyone remains respectful and leading by example.
Yes, thank you so much. Thank you. I love that answer. Everybody needs to lead by example, and as maybe the head, there's need to create a space for everyone to speak up. Yes, and I love the strategies, the below the line and the above the line. Thank you for that. Okay, the last question will be taken for today. There's last question here. The question is, the person is asking, in many hospitals in low and middle income countries, they lack the capacity to implement, the program you mentioned, the operating room residency. So, so the person is asking, what strategies can be adopted to address this challenge?
So, which aspect of it? Because I'm going to challenge you all. what is the barrier? Because you don't need, what barriers do you have? If you have an operating room and you have people interested, then you can create a program. You don't need a fancy school. You don't need a fancy anything because you have an operating room. Do you have an operating room? Do you have willing individuals to teach? All it takes is one. You should start with one to start a program. Obtain the tools that you need to start the program. I shared some in my presentation. I'm going to email the presentation out to the operating room global. I'll email it out to the contact person, and you'll have those resources. But in low income, and I'll say this, the United States seems rich globally, to our global counterparts, right? But it is resource poor in a lot of areas. Does that make sense? So it may be rich, but it is resource poor in a lot of areas. At my hospital, we don't have an OR residency program. We don't have the infrastructure to have an OR residency program. But what we do have is an educator, we have operating rooms, and we have mannequins. You create your own space with what you have. You don't need all this big fancy. No, you don't, because that does not apply to your space. So if it doesn't apply to your space, it's not going to work in your space. So you utilize what you have at your organization and at your facility to make it work. The same way you do cases every day is the same way you can teach nurses and teach techs how to become part of the OR team. Gather your resources, create a plan, create a strategic model, network and resource with other individuals that have created these spaces, and make it work, and trust in yourself that you can make it happen. Don't think because you don't have what the higher income countries have that you can't make it happen.
Thank you so much for the answers. Okay, I'll be handing over the mic to my colleague to give us the closing remark. Thank you.
Okay, thank you, Mrs. Ugwu. Dr. Nikki Washington, you've just been fantastic. I'll tell you, we had over 70 participants on this webinar, and I can tell you your message would go far. You did so much talking about support, cooperation among team members, conflict resolution, which is key, fundamental to where you have more than 1-2 persons, especially where there is a shortage. Communication, which you further defined and gave, insight into how it will affect. You spoke so much about accountability. Without accountability, frankly speaking, we won't go anywhere. And then the big one, I was just waiting for it when you talked about gossip. It does nobody any good. I'll tell you. I know. So with all this, you've done pretty well. So just know that from TORG, we're grateful to have had you, do this presentation for us. And I know as ambassadors, we're going to take your message far and try in our own small way to help in bridging the gap so that this shortage would, in a short while, would come to pass. So once again, accept our thanks for participating. And please, when we come knocking again on your door, please oblige us. All right. Thank you very much. Going forward, we'd like to also thank the founder of this TRG, that's Professor Adebukola. It's just been fantastic. We've seen TRG grow from grace to grace. It's grown from country to country. We thank the BOT members for the support. And at the end of the day, there wouldn't have been this presentation if there were no participants. So the over 70 participants we had here today, we want to say thank you all again. It's been a wonderful program. At this point, I do not know if the CEO has anything to say. Otherwise, I will want to say thank you very much, and let's look forward to another webinar and look forward to another beautiful presentation. Thank you very much, and God bless you all. Bye, Dr. Nikki.
Bye. And y'all reach out to me, please. I'm here. I'm here to help.
Okay. All right. Thank you.
Thank you, everyone. Bye.